All right, so let me give you a quick background on this group CBTP engagement and retention presentation today. I've had the opportunity now to meet with a couple of different groups, and I say specifically thank you to the focus group at Valley Cities. We should update that because we also had the opportunity to have some of these conversations with Brittany and some other folks when we went back out there to do some new training. But we've had the chance now, and actually with the Echo Clinic itself, just to talk with people about how to improve engagement and retention if people are struggling with these kinds of things. And so this is a reflection of a lot of these conversations that we've been having with groups around the state and over time related to group CBTP. All right, so the first set of things that we covered were barriers, and so this is sort of, again, taking this feedback and trying to boil it down into some categories that we can all think about and talk about together. In trying to get these groups up and going in places either where CBTP is not being done in any form, or places perhaps where groups are not actually a big part of the clinical offerings of a particular clinic. One of the barriers that people were seeing to implementing group CBTP was skepticism from staff and other clinicians. So people saying that group therapy is not appropriate for psychosis, that therapy is fine, but they don't have any of the right clients, because not because they don't have people who hear voices or people who have thoughts that other people don't accept, but because they look at somebody and say, well, they're not hearing and responding to voices 24 hours a day. You know, they're better than they were when they started here, so they don't need any, additional help, right? So be on the lookout for, barriers to referral where people are either thinking that this doesn't work, in which case, hopefully you've got some information from our trainings and from the materials that we've given you, where you might be able to talk with other clinicians at your site about it, or if need be, we are happy to try and figure out a way to come and have that conversation with folks, with clinicians particularly. I mean, Sarah's already done good work with all of your agencies in terms of implementation of this, but I know sometimes that agency level implementation does not necessarily mean that the clinicians are on board with what we're trying to do here. So we'd be happy to have some of those additional conversations if it would help. But mostly we want you to be the best advocates for the group CBTP in your sites, because you are familiar with those folks and you're the ones who are going to be doing the work on a day-to-day basis. So either people not knowing that it works, or thinking that their clients are not psychotic because they're not in their worst kind of episode right now. It's perfectly fine to have somebody with a diagnosis of schizophrenia who's doing pretty well, doing pretty well, and wants to come to group to learn how to deal with these things, cope with stress, and deal with symptoms as they arise over the course of different episodes of the episodic illness. And then from potential participants, we've already talked about this a little bit in our Echo Clinic, is that we have to be careful if we're calling it CBT for psychosis, if there are going to be people that we want in the group who are going to say that I'm not psychotic, people who are socially anxious and have other reasons why they don't like groups, and people who hear that it's 24 weeks and that they're not comfortable making a commitment to 24 weeks. So these are potential reasons from participants that we are hearing that they might not be interested in group CBTP. There are reasons related to our own disorganization and that of our clients that it's hard to get a group up and running and get that engagement and retention that we want. And obviously the biggest things that we have heard from our clinicians, that it's hard to fit everything together and start and run a group. It's hard sometimes to get the room, it's hard to get approval. Sometimes there's paperwork that needs to be done, and it can be hard to move that through the system. And then we get to the point where we're trying to get a co-facilitator going, and we're trying to meet with the co-facilitator before the group, and so on and so forth. So those become time demands. And then once we've got a lot of those logistical and organizational issues squared away, we find out that there are logistical barriers for our clients. And then there might be symptom exacerbations again over the course of an episodic illness, where people are maybe not making it to group, and that makes it hard for them to catch up, or to feel like they've got good rapport, good group dynamics going with the rest of the group. Uh, the administration of the group can be difficult. In places where so this is kind of complicated because there are some agencies that are different from others in terms of what we have tried to do in introducing CBTP. If you're an agency that has step 1, step 2, and step 3 providers, there are cases where we wanted assessments. The STEPS system required assessments to be done, so we knew we were getting people into the right groups, and so not having assessments done meant people were not getting referred. And then there were these potential barriers for the clients because there were a lot of steps required to get somebody enrolled in a group. The clients didn't know the people involved. Some of the clinicians didn't know some of the people involved. And so that made it difficult to get all these steps done in order to get somebody enrolled in a group. People had a lot of success in some cases of getting a group going, and they had to put some people on the wait list, and then people stopped, some of the people stopped coming to the group, but they found out that those on the wait list were no longer as enthusiastic or ready as they were when it was first rolled out. And then one of the big things that a lot of us, we've heard from a lot of people over the course of the clinic, is that having the right space, equipment, and time of day for this group has been really important. And the time of day, well, we can talk about what has generally worked, but having the right space, the right equipment, and the right support has been very important. And when those things are not present, it's been a barrier to getting this going. So what are some of the solutions that people have come up with over the course of the experience of running CBTP groups? In terms of skepticism from staff and other clinicians, one of the things that has been very helpful as people have run the group and they've had clients graduate from the group is to introduce those satisfied graduates both to other clients and to other clinicians. You can have people come to the group, clinicians or other folks from your agency come to the group for graduation and see that kind of ceremony and enjoy that. It's not great to have them come to other sessions, but to come to the graduation is a nice step and can actually show the group members that people around the clinic are interested in the fact that they have gotten through this and that it's kind of a big deal. It's a nice thing to have gotten through. And then bring some of the materials to staff meetings and other kinds of things if people are skeptical about what the group is. And let them know that CBT works for hallucinations and delusions, right? That this is an empirically and evidence-based treatment and that we really want to get more people involved in it. And then, just the thing that we kept hearing is we as clinicians have to continue to be committed to this work. So people have been talking with med providers because the med providers are looking for additional solutions for their patients. Peer support specialists have obviously been great for this program rollout because they're able to talk with a large group of people about why this might be helpful from the lived experience perspective. So it's been very helpful for us to have all of that. And then in terms of addressing skepticism from potential participants, and again, we've gone over some of these things, but considering alternate group names, just having different things that you might call the group so that the word psychosis doesn't turn people off. Some agencies have introduced a pre-CBT group at Valley Cities. They called it Our Stories, and we've talked about it a little bit, but it's this idea of a group setting that's a little less personal in terms of describing symptoms, but is an opportunity for people to tell the stories about themselves that they would like to tell over the course of the group. And in fact, they don't have to say anything out loud, but it's sort of the exercise of sort of thinking about their lives and coming up with them. So we can certainly talk with folks who might be interested in having that introduction to group. And again, for potential participants, you can invite them also to the end of the group or to the graduation so they can see kind of what it's all about. And then, in terms of talking with people about the group, get them thinking about, we want you to just take it 1 week at a time, and you don't have to think about 24 sessions. Let's just think about the session this week and whether that material will be useful to you. Disorganization. A lot of the things sort of depend on how your agency is rolling out CBTP generally, but There tends to be care coordinators and other folks who you want to be on very good terms with, so that they can help get folks steered into the group CBTP. And then just building your own team right there, to, with peer support specialists, people who might be step one trained, but helping build a network of people within your organization the same way that we're trying to build a network of providers throughout the state with these echo clinics, to build the team, to build the momentum to getting more and more people enrolled in these kinds of groups, and seeing the benefits over time. We've had some people make good suggestions about, if you're trying to find potential clients and you're not sure where to find them, does your electronic medical records have resources that you might rely on to run reports to identify clients with the right diagnoses, who might be invited to group, or who at least you might then find out who their clinicians are and go talk to them about whether they might be a good referral for group. So I know some folks even on this clinic have done things similar to that in order to get folks enrolled in the CBTP group. In terms of disorganization for clients, we've had a lot of folks who receive incentives for attendance. That's not going to be the kind of thing that works in every agency, but whatever you can do to make it enjoyable to come to group is obviously an incentive. And then whatever resources people might have in terms of transportation, just helping get those coordinated as the group gets going, so people feel like they can get to group on time. Do they have bus passes? Do they have access to other ways to get to clinic? Do we need to think about the time of the group so that it's optimally structured for people who have a job? Those kinds of things. Just trying to reduce those logistical obstacles absolutely as much as possible. And again, if they're not familiar with the group process, it might be good in your agency to have something like that intro to group, where people are getting the experience of coming and sitting and talking with other people, but they're not delving into the CBT material just yet. That's also a good way to have a wait list that stays engaged. The folks on the wait list are going through the intro to group, while the CBTP group is running. Yeah, I think I've actually talked about most of these. I do want to come back to this idea that we have generally heard from the clinicians running this group that afternoon groups are way better than groups at any other time of the day. Midday, midday. That's all I need to say. That's what we have heard. If your experience is different from that, we would love to hear more about it. Sorry, skipping through there. The one thing that we've just heard over and over again, though, is as this is new to your agency and new to your clinicians, it's just really, really critical to help people understand the value of CBTP generally, and CBT groups. You can help a lot of people by running a group, 6, 8, 10 people, or 2 or 4, depending on where you are in the getting ramped up process. But you can start helping a lot of people in fairly short order and you want to sort of help people in your agency know that this is going on and try and get more folks in, get more folks trained, and see how far we can expand our reach with CBTP.